Topical will share her screen during our presentation. Good afternoon, Dr. Price, how are you?
Thank you very much. Hopefully, any minute now, you'll be able to see my screen. Good. So it says they can. That's brilliant. I'm going to try and turn it into a slightly bigger screen. Is that correct? Or are you just seeing, doesn't matter if you're just seeing the one screen. Has it moved on to the second slide? Perfect. Okay, good. So I'll just do it manually. Okay, perfect. Okay. So thank you very much for asking me to give this talk. I'll just run through my views on this. As Helena very kindly said, consultant rheumatologist. I'm based in the Great Western Hospital in Swindon. And I specialise in Sjögren's syndrome, but obviously people with lots of other connective tissue diseases. Now, the first thing to say as part of this webinar is that autoimmune disease is far commoner in women overall. So unfortunately, although we're beautifully put together in many other ways, we are more prone to autoimmunity, and that's probably due to a combination of factors. But I often explain it to women by saying that actually our immune systems are more complex because they have to cope with pregnancy, and pregnancy is a very difficult time for your immune system because it has to not reject the baby. So you have a very more complex immune system than a man's immune system. But unfortunately, as a consequence of that, it's a little bit more prone to problems. And we also have estrogens, female hormones, which can affect the immune system. So to give you a flavour of how much commoner autoimmunity is in women than men, I'm going to point out some figures here. So Raynaud's affects twice as many women as men. Scleroderma, we've got a 3-to-1 ratio, so 3 times as many women as men. And when you get to lupus and Sjögren's, which is the condition I specialise in, the ratio goes up to 9-to-1, and for thyroid disease, it's 10-to-1. So that in itself is, I think, quite interesting and tells you why so many of our patients and members are female. Raynaud's is a very common phenomenon. It's probably an exaggeration of a completely normal response. So if I were to drop one of you into the Arctic Circle where it's very cold, your reflex reaction will be for the blood to pool in your heart, lungs and brain, which is where you really need it, at the expense of your hands and feet. And in fact, that is what frostbite is. Frostbite is where you've put yourself in a situation where the blood has left your hands and feet to try and improve the circulation and blood supply to your major organs. But in patients with Raynaud's and Scleroderma and other connective tissue diseases, the Raynaud's is triggered at an inappropriately low temperatures. So you can get Raynaud's just moving from a warm room to a less warm room, walking down the supermarket aisle, the freezer aisle in Tesco's and so forth. It can also be triggered by various other things. So vibration. So many of you may find that driving a car, the vibration from the steering wheel can set off Raynaud's, and emotions can. So if you're very stressed, you can suddenly get an attack of Raynaud's. The classical Raynaud's is where it goes white, and it's beautifully illustrated in this picture here. And then as it warms up, it goes blue and red. Not everyone has that classical triad, to be fair, and I think we can afford to be fairly generous in our definition, and the treatment is much the same, whether you fit exactly into the diagnostic category or not. And you may know that we tend to split Raynaud's up into primary and secondary, and primary Raynaud's is the commonest form, and it's where it occurs as a standalone condition. And secondary Raynaud's is where it occurs in association with another autoimmune disease, most commonly Scleroderma. Well, not most commonly, obviously the Scleroderma is the one, it isn't common, but that's the one we're most interested in today. But it can occur in any of the autoimmune diseases, and I see it in my Sjögren's patients, and we will see it in patients with rheumatoid and so forth. It's worth bearing in mind that up to 20% of what we call the normal population will suffer from Raynaud's, and there is this female excess, as we discussed. So just having Raynaud's itself may not be a worrying feature, although it will need treatment on its own merits. Hormone changes are very important in Raynaud's, and it is definitely exaggerated by cold-induced triggers, vasoconstriction, but there is a very positive association between estrogen levels and Raynaud's. So we commonly see Raynaud's starting at around the time of the menarche, when your periods first start, when your estrogen levels start to rise. it can go one or two ways during pregnancy, because pregnancy is obviously a state where you do have high estrogen. But interestingly, the pregnancy state also improves circulation. So people have a heightened circulation during pregnancy. So sometimes actually during pregnancy, it actually gets a bit better. I personally recommend that patients try and avoid the estrogen-containing pill and HRT, because the estrogen content of those treatments can drive Raynaud's and make it worse. And I have seen patients who haven't previously had Raynaud's pitching up at the time of the menopause when they've put on HRT, and that can trigger it. And obviously in teenage girls, going on the estrogen-containing pill can trigger it, although they tend to use progesterone-only pills these days in younger women. And many of you will have noticed a change in Raynaud's during the course of your menstrual cycle, and it's probably worse in the mid-cycle when your estrogen level is at its peak. So some of you may have experienced something called Raynaud's nipple. Now, this is where you get Raynaud's of the nipples, and it's worth pointing out that you can get Raynaud's of any extremity. So we do see it in the ears and the nose, as well as the hands and feet. Obviously, affecting the nipples is pretty unique to women, and it can be a real problem in breastfeeding a baby, where you get these very painful blanched nipples. They go almost cold and dead when you're trying to breastfeed, and it's probable that it's a manifestation of your Raynaud's, but it's being triggered by the excess stress that you're under with trying to feed a baby. It can also be precipitated by going out in the cold. Some ladies who get it during breastfeeding find that it's misdiagnosed as thrush or infection of the nipple, because it's quite common, particularly when you first breastfeed a baby before you get the hang of it, for the nipples to crack, and that can allow infection in. And sometimes people are given repeated courses of antifungal treatments and antibiotics, but actually what they need is treatment of their Raynaud's. In terms of managing Raynaud's, there are a few things that we recommend. I personally recommend ginkgo biloba. It's an over-the-counter remedy. It can improve circulation, and it's usually well tolerated. A lot of people will try omega-3 and fish oil treatments, and again, there's a little bit of evidence supporting those. Obviously, it's important to be practical and to avoid the cold and avoid exposure to cold. And when you're thinking about staying warm, you must think about keeping all of you warm, not just your hands. So you need to keep your core warm so that your core doesn't start pinching the blood to warm you up. So that means things like thermal vests, etc. And I'm a great believer in people going off to ski stores. You can buy some amazing undergarments and stuff now, and layering, wearing thin layers close to the skin and fluffier layers further away to trap warm air around yourself. If that's not enough, then you can move on to taking medication. And the most used medication in the UK is probably nifedipine. And nifedipine is a very old-fashioned blood pressure tablet, and which almost as a side effect dilates up blood vessels. And it's one of a group that we call the calcium antagonists. We do use other blood pressure tablets as well. The drawback to all of these, though, is that blood pressure tablets inevitably drop your blood pressure. A lot of women with Raynaud's have fairly low blood pressure anyway, so they can make you a little bit lightheaded and woozy when you first take them. So if you're given a new tablet for your Raynaud's, top tip is to always take it at night when you start off, just to make sure you can tolerate it well. Gabapentin is an interesting drug. It's a nerve pathway blocker, and we know that you do get nerve involvement in Raynaud's. So again, there's a feedback loop in a normal person, whereby the nerve endings in your peripheries send messages to shut down the blood vessels. And using drugs such as gabapentin, which can block those nerves, can actually help. And we also use a whole range of other drugs, things like fluoxetine, and even sildenafil, which some of you may have come across under its trade name of Viagra. And sildenafil was obviously, it was originally designed actually as a blood pressure drug, and then incidentally found to be good for erectile dysfunction. But it's really good for Raynaud's. It really dilates up the blood vessels very, very well, and it can be a very effective drug. The main drawback to it, again, is its effect on blood pressure, where it drops the blood pressure and can make you lightheaded. So moving on to dryness. So I'm focusing on women's issues. So an issue that women get particularly, and I see a lot of in my clinics, is vaginal and genital dryness. Now, Vaginal and genital dryness are incredibly common in the normal population, and as many as 3/4 of women will suffer from this post-menopause. But obviously, if you've got an underlying connective tissue disease, particularly if you've got Sjogren's, but also with scleroderma and lupus, you may well get dryness at a much younger age. And it is a problem because it's not only uncomfortable, but it can make you more prone to infections. So if you've got dry skin, then you're likely to get tears and cracks in that skin, and that can allow infection in, and it can allow thrush to develop as well. There are a few rules about looking after genital skin. Don't use ordinary soap, use what we call a soap substitute. So these are far gentler than standard soaps. They're usually liquids, and many of them you can buy over the counter. Some of them are on prescription. So Oilatum's a good one, and so is Aveeno. And I've put those two examples in on purpose because Oilatum is a very traditional paraffin-based moisturizer and emollient. Whereas Aveeno is an oat-based moisturizer, and they both have a whole range of products, including bath, stuff you add to the bath, stuff you wash with, and stuff you use as a moisturizer. Most people will try the oily-based, paraffin-based ones first, and they do work very, very well, although you do have to put them on regularly. And you do have to persevere. 1 or 2 people don't find the paraffin ones particularly helpful, and some people find them sensitizing. They make them actually worse rather than better. And if you're in that group, you might want to try an oat-based moisturizer. So these are produced in a different way using oats. Aveeno is probably the market leader, but there are a number of them on the market. And if you walk up and down the aisle in your local pharmacy or Superdrug or Boots, whichever one you use, you'll find different ones. And GPs can prescribe versions of Aveeno or oat-based moisturizers, and they can be really very helpful. The next thing to point out is that if you're using a moisturizer within the vagina, it is absolutely critical it's acid based. So most of our skin and our mouths and so forth are alkaline or neutral pH, but the vagina is very specifically acidic, and that's important because it's designed to be acidic, and if it loses that acidity, then that can make you particularly prone to thrush or to something called bacterial vaginosis, which is where you get bacteria overgrowth. And if you do get that, it can be quite unpleasant because you can get a discharge down below, which can smell sometimes a little bit fishy. So if you've ever experienced that, you'll know that it's not something you don't want to get again. So use an acid-based moisturizer. Now, again, there are some really good products on the market, many of which you can buy over the counter or online if you find it difficult to go into a chemist and ask for these products. Probably the market leader is one called YesVM. It stands for Yes Vaginal Moisturizer. It's very discreetly packaged, it's very easily available, and it's very effective. And some versions of this will be available on prescription if you talk to your GP. If you get a lot of vaginal problems and you are postmenopausal or even in those perimenopausal years, you might benefit from an estrogen-containing product as well. So if you look at what actually happens to the genital skin postmenopausally, the thickness of the skin reduces dramatically. The skin becomes thinner. And if you've got thin skin that is dry, it's very prone to tearing and cracking. So using an estrogen-based topical moisturizer, and there's various ones on the market, or a pessary, which is where you insert into the vagina, can make a big difference. And I do have a lot of patients who will be using a estrogen-based product and a moisturizing acid-based product. And what I normally recommend is if you're starting a new estrogen-based product, you use it regularly for a couple of weeks just to improve the quality of the skin, and then you reduce it down and maybe use a maintenance dose twice a week. A couple of other very simple things you can do. Please stick to cotton underwear because nylon underwear can make you sticky and it can encourage thrush growth. Obviously, avoid perfumed products down below, and be aware when you're buying sanitary products that nowadays some of the panty liners and sanitary products have got perfumes in them, so try and avoid one that's got perfumes in. And then another top tip is to avoid very dark colours. The dyes they use in some underwear, particularly the black dyes, the very deep black dyes, can be very irritant to sensitive skin. So switch to lighter colours or white underwear. Right, so that's moving on from that and talking about fertility and pregnancy. So it's worth pointing out that this will depend to a degree on what your underlying diagnosis is. I'm very aware that SRUK has a mixed membership of some patients with Raynaud's, some with scleroderma, and others who have other connective tissue diseases. So some of the numbers I've put here only apply to a certain percentage of you. Bear in mind that fertility, your ability to get pregnant, is usually normal. Now, there are some exceptions to that, and apologies for this typo on the side. So if you've had previous cyclophosphamide treatment, that can reduce your fertility. But in many patients with underlying connective tissue diseases, your chances of getting pregnant are actually pretty much normal. However, there is often a slightly increased miscarriage rate. Now, that can be very difficult to measure and very difficult to advise patients on, because we don't normally measure miscarriage rates in normal people. And actually, depending on which studies you look at, probably about 6%. 6 in 100 normal pregnancies ends in a miscarriage. But many of those miscarriages are very early on and are not actually reported. So they have looked at miscarriage rates in a number of conditions. So in scleroderma, which is what Blachowicz, the name I put at the bottom, specifically looked at, they gave an odds ratio of miscarriage of around about 1.6. And what that means is that if a normal person's risk of miscarriage is 1, a person with scleroderma has a miscarriage rate of 1.6, so an increased rate of miscarriage compared to the normal population. Now, depending on what your underlying diagnosis is, that number will vary. It's very difficult to estimate in some conditions. Probably in Sjogren's it's about 1.3, so it is slightly up, but not up as much as scleroderma. And bear in mind that a lot of these figures depend on how well you are when you conceive. So a good rule of thumb for pregnancy in connective tissue diseases is that you should always discuss with your team, with your doctor or your nurse, whoever looks after you, before you start trying for a baby, to make sure that your condition is as good as it can be. Because if you're well at the beginning, the chances are your pregnancy will go well. If you're sick at the beginning, that puts you into a higher risk category. The other things that we see are early births and low birth weight babies. And these are both very common in scleroderma and in patients with other connective tissue diseases. And again, there's a figure there to give you an idea of how common it is. So bearing in mind that the normal population will have a risk of a preterm birth of 1. In scleroderma, it's 2.4 times as common to have a preterm birth and 3.8 times as common to have a low birth weight baby. There are similar, but not quite such high figures for Sjogren's and lupus patients. The other question that patients ask is, how likely is it my disease will get worse in pregnancy? Well, probably not very likely. If you've started off well, the chances are you will continue well through pregnancy. In fact, there has been 1 or 2 papers suggesting that the skin can improve in pregnancy in scleroderma, but there are a few situations where it can get worse. And the main risk for that is where you've already got a condition called pulmonary hypertension. And that's why patients with scleroderma will be having quite often echocardiograms or lung function tests to pick up pulmonary hypertension, which is where you've got raised back pressure in the lungs that can have an effect on your heart. And unfortunately, that particular complication of scleroderma does make pregnancy much more risky. And that's something you should definitely do. If you've got that diagnosis, you should definitely have a very careful discussion with your doctor before even thinking about pregnancy. And then the other thing to say is that pregnancy itself can do all sorts of things to you. It increases your circulating blood volume and it can push your blood pressure up and it can affect your kidney function. And of course, those are things that can happen in underlying connective tissue diseases anyway. So it's very important that you are monitored very carefully in pregnancy. So I usually warn my patients who are starting families that they are people who do need to be booked into the consultant clinic. They're people who do need to be seen regularly, and they will need more in the way of monitoring through pregnancy, and maybe a little bit of extra care. I would definitely recommend an in-hospital birth. Ask for every test and review that you can get, because you want to maximize the chance of getting through it safely. So planning is very, very important. And then assuming and hoping you have a successful pregnancy, the next step is breastfeeding. Now, the first thing to say is that breastfeeding is safe in connective tissue diseases, including scleroderma, and almost all the drugs we use, with a very few exceptions, are safe in breastfeeding. So nifedipine, for instance, which is the commonest one you'll be on, is very safe. Hydroxychloroquine is very safe. There are a few drugs that aren't recommended in breastfeeding. So methotrexate is one and cyclophosphamide is another. But if you're in doubt, always check with your specialist, but don't assume you have to stop things. In fact, there is some evidence that stopping drugs in pregnancy can be as bad as taking one that doesn't suit, because what you don't want to risk is a flare of your disease. So don't suddenly stop anything. Always get advice first. A lot of ladies, and I deal with Sjogren's a lot, complain that they struggle to breastfeed. And actually, I think that's probably because the breast is a secretory gland. And if you've got Sjogren's, you will know that it affects your secretory glands and secretions are reduced. So maybe as part of that, breast milk is also reduced. I think it's important to say to women that you mustn't get too stressed about this. Although, we're all great advocates for breastfeeding and so forth, if breastfeeding is difficult, formula milk is absolutely fine for your baby. It's very carefully manufactured these days, and you shouldn't get yourself in a complete tiz about breastfeeding if that's not the right thing for you. So always take advice and don't get stressed. And getting stressed actually makes breastfeeding much more difficult. And having done it myself, breastfeeding isn't easy. It doesn't necessarily come naturally to people, and do ask for help. I think midwives are getting better at supporting you, and there are people like the NCT, National Childbirth Trust, who are always on hand and are very happy to help if they can. And then at the other end of the extreme, I wanted to just mention about the menopause. It's had a lot of press recently, the menopause. It's worth pointing out that many women with connective tissue disease do have a bit of an early menopause and may get a little bit of what we call premature ovarian failure. In the normal population, the best determination of when you're going to go through the menopause is the age at which your mother had her menopause. So if she's still around and you ask her, she may be able to give you some clues, but quite often you'll go through a bit early if you've got an underlying connective tissue disease, and also if you've had particular treatments, especially cyclophosphamide. Exactly when you go through the menopause may be determined by your underlying condition, your previous treatments, I've mentioned cyclophosphamide, and also how long you've had your condition. So people who've developed scleroderma at a very young age often do go through a much earlier menopause. And bear in mind, the menopause is not all bad. There may be some positive things. Migraines often get better post-menopause. People with endometriosis and painful periods find that they improve post-menopause. I would put in a little bit of a caution about hormone replacement therapy. Think carefully about it. Take advice from your rheumatologist, from your specialist, and your GP. HRT isn't always the best answer if you've got an underlying connective tissue disease, because the estrogens in it can make things worse. However, topical estrogens, this is where you're putting estrogen creams and pessaries on to improve genital health, are safe. And I once went to a lecture given by an eminent gynecologist who said that she felt that the topical estrogens creams were safe even in women with breast cancer. And she gave an estimate that if you were to use an estrogen pessary for a whole year, that would only be equivalent to a week's worth of actual HRT. So she felt it was a very safe and very low dose. The other thing to say about the menopause is that lots of things change at the menopause. Our bones can start to thin and our muscles can start to weaken. And all the evidence shows that the fitter you stay, the less likely that is to happen. So it's really important to stay fit to have a healthy menopause in later life. I know a lot of you wanted to know about cancer. I think it's worth pointing out that cancer is a very common condition and it's increasing in incidence. We're not altogether sure why, but that might be because we're better at treating other things and people are less likely to die of other things. And we are, on the whole, living longer. It's estimated that 1 in 3 of us, 1 in 3 of the healthy population, will develop cancer. So it's really difficult to estimate whether there's an increased risk of cancer in patients with connective tissue disease and with scleroderma in general. And I think I've looked at some of the evidence and I've got it on my next slide and I'll talk it through. I think overall it's unlikely to be significantly increased, but the evidence is very confusing. So these are some of the studies I've looked at. And the problem we've got in the literature is different studies have come up with different answers. So these are a summary of probably some of the biggest and more recent studies looking at cancer and scleroderma in particular. And there was a Danish study back in 2010 that looked at over 2,000, mainly women with scleroderma, and found that the risk was 1.5. So going back to our original talk about risk ratios, that would mean that a normal person without scleroderma would have a risk of 1, and your risk would be 1.5. So that, that does show that you're at increased risk, although not massively increased risk. Interestingly, they found that the risk was highest in men with scleroderma, and the two cancers that were the commonest were lung cancer and lymphoma. They didn't in that study find any association with breast cancer at all. There was the second one I've got here summarized was what we call a meta-analysis, and that's where they pool data. So they go to the literature and they find studies, in this case 16 studies. They add up all the patients in those studies, which came to 7,000, and then they pooled the data. Now, a little word of warning with this. They're using statistics to interrogate the data. And if any of you have got any experience in statistics, you know that you've got to use those very carefully, because you can come up with unexpected answers and sometimes the wrong answer because you assume things incorrectly. So a very easy example of this is that if you go back to the 1920s, when the incidence of lung cancer started to increase in the UK, the first thing they thought of and blamed was roads. They said, well, we're putting tar down and building new roads. That must be what's increased the risk of lung cancer. But in fact, we now know, and it seems obvious now, that it's smoking that increased the risk of lung cancer. So sometimes you look for something and you find the wrong answer. Just be a little bit careful interpreting studies. But nonetheless, they did find that there was a slightly increased risk of cancer in patients with scleroderma. They estimated the overall risk at 1.75, so a little bit higher than in the Danish study. Again, they found this excess of lung cancer and hematological or blood cancers, but again, found no association with breast cancer. The next study I picked out was done in 2013 as well. Similar types of numbers, 6,000 patients, but actually fewer studies. So, larger individual studies in this. Again, they found the risk was up slightly at 1.6. Again, they confirmed it was males more than females. Again, they picked out the lung cancer and hematological cancer. And then the final study I looked up in 2018 looked at 2,300 patients and found 8.6% had cancer, which actually seems slightly lower than you would expect, but it wasn't a very long study and it didn't follow them up for very long. And that's probably a problem with this study. It did find an increased risk of cancer in patients who carried a particular antibody, RNP, ribonucleoprotein antibody, and a reduced risk, interestingly, of cancer in those with anti-centromere antibodies. They found that diffuse scleroderma was associated with breast cancer to a degree and limited scleroderma with lung cancer. But I think caution on this study, it's small, 2,300 is not very many, and it was over a short-term time frame. So I think it's fair to say that the evidence on cancer and scleroderma is mixed, and some of it may reflect the background cancer risk. Of course, you've got to bear in mind that cancer can change in population. So in part, it depends where the study was done. Was it done in the UK? Was it done in Japan, which has a very different pattern of cancers, or on the continent? And the other final thing that I think may affect some of the shorter studies is what we call paraneoplastic connective tissue disease. So we've long known that some cancers can present with features of connective tissue disease, and Raynaud's and even scleroderma can actually be the presenting feature of an underlying cancer. And in those cases, almost always, the cancer declares itself within 2 years of the presentation of the connective tissue disease. So I think it's hard to be conclusive about this, but the evidence on the whole is fairly reassuring. The next thing I was asked to talk about a little bit was gastrointestinal issues, gut problems. Again, these are not specific to women, but women seem to get more IBS. So irritable bowel syndrome can affect up to 20%, 1 in 5 of the normal population, and it is female predominant. We don't really know why. And IBS can cause intermittent gripey tummy pains, some diarrhea and some constipation, bloating, and it can be cyclical, and it can be quite a distressing and unpleasant condition. Tests in IBS are invariably normal, nothing is found, and patients are managed conservatively, just with attention to diet and stress and so forth. Esophageal problems, esophageal dysmotility in particular, are commoner in scleroderma. In fact, they're a feature of scleroderma and are also seen in other connective tissue diseases as well. And that can affect swallowing and increase your risk of heart heartburn. Another problem we see a lot of them people complain of is what we call hypo motility or slow transit. And this is linked to esophageal dysmotility in a way, because it's where the peristaltic muscular waves in your gut don't work well. And in a normal person, there's a very smooth wave, peristaltic gastric wave, goes from the top to the bottom, smooths food and stuff along. That doesn't work very well in people with connective tissue diseases. It's particularly bad in people with scleroderma, and that can affect your digestion. You can get malabsorption, and that's probably multifactorial. It can be in part due to slow transit. It can also be due to thickening of the bowel wall, to vascular problems, lack of blood supply to the bowel wall, and to absence or low levels of pancreatic enzymes. And you can get something called SIBO, or small intestinal bacterial overgrowth. And that's where the bugs that we would normally find in the large bowel have migrated up and are growing away in the small bowel and causing problems. And finally, there is an association with celiac disease. There's a particular association with Sjogren's and celiac disease, but celiac disease in general is more common in patients with connective tissue diseases. So what can you do about it? Well, you have to manage it. You have to be careful with your diet. So eat small, regular meals, chew properly, have water with your meals. Taking a PPI, so a omeprazole or lansoprazole, one of those sort of drugs, can reduce acid reflux and protect the lower esophagus from heartburn. I often recommend patients trial marshmallow root extract. It's a very good soother, helps with heartburn and so forth. It's a natural remedy. You can buy that over the counter in places like Holland & Barrett. Diets can sometimes help. So if you've got slow transit, what can happen when you've got slow transit is that foodstuffs can ferment in your gut. So if that's the case, you might benefit, even if you haven't got celiac disease, from switching to a low gluten diet. And the other diet that lots of my patients try is something called the Low Fodmap Diet. And that's a diet that looks at fermentation products and cuts out certain foods. You'd need to Google it to get a diet list. It's not too bad. And what most people would do is they'd Google the list, they'd start with low FODMAP foods, low fermentation products, and then over time slowly reintroduce things to find a diet that works for them. If you've got small intestinal bacterial overgrowth or SIBO, you're likely to need cyclical antibiotics on prescription, and you'd need to discuss that with your GP and specialist. If you've got definite pancreatic enzyme insufficiency, there is a test you can have done to look for that, which is a test where they look at your poo to see if you've got good levels of pancreatic enzymes. And if you haven't, you can have supplementation. And then finally, if you've got bile salt problems, so if you've got an excess of bile salts in your gut, then you can have treatments such as cholestyramine to mop up those excess bile salts, which can make things more comfortable for you. So just to conclude, autoimmunity is common in women. I didn't need to tell all of you that, but I'm just reminding you. Self-management does help. There are things that you can do. Pregnancies are by no means impossible, but you must plan them to improve your outcomes. So thank you very much for listening. And I think if I stop sharing, Helena was going to see if she could pull some questions off the chat for me to answer.
Thank you very much, Dr. Price. That was an amazing presentation. I think that will resonate with a lot of us. For me, I really appreciate your messaging about breastfeeding. Thank you for that. I wish more people would say that at the time. So yes, I would now like to invite our participants to send us your questions, which I can then put to Dr. Price on your behalf. You can do so via the Q&A feature. So if you hover over the Q&A on the Zoom app, you can send us a question that way, and I can put them forward. I can tell you, Dr. Price, we have 46 people joining us today. So thank you all for your support.
Good.
We really do appreciate it. Thank you for being here with us today. We hope you're finding it useful. You will receive a post-webinar survey after the webinar. So if you are able to take a few minutes to fill that out, we really do value your feedback, and we use that to shape our services in future, to ensure that we're meeting the needs of our members and our community. So thank you, and thank you again for supporting us today. I think it's time to crack on with the questions, because they're coming in. The first question, Dr. Price, do excuse my pronunciation. Does gabapentin help hot flushes in the menopause? Is the question.
Well, I see what you mean. So possibly. So gabapentin is a really interesting drug. So gabapentin was actually produced originally to deal with. It was actually an anti-epileptic drug. So it's designed to damp down electrical activity in the brain and the peripheral nerves. Now, I'd have to be honest and say it would not be my first choice as a treatment for hot flushes. But I suspect it probably would help a little bit, but I don't think I'd use it as first line. I think it's, unless they were very, very disabling, I think I would suggest other simpler remedies, to be honest, like a fan and cooling yourself down. And there is clomiphene, which is the other drug that we do sometimes use. And all of these are on prescription. So I think by all means discuss with your GP, but I wouldn't rush to gabapentin as my first line.
Thank you, Dr. Price. Next question is a bit more general. Can scleroderma contribute to infertility? Please.
Yes, I'm sure it can. Yes. So as I said at the beginning, in general, fertility is not impaired in these conditions. But that's to say that any chronic underlying condition that runs you down can affect your fertility. We know that people with scleroderma and some people with connective tissue diseases can get a premature menopause and premature ovarian failure. So yes, it can be a contributor, but it is not necessarily so, if you see what I mean. And if you've had cyclophosphamide, yes, that does contribute to infertility as well. I think if you have got scleroderma and you want to start a family, I think I would bring it up with your doctor sooner rather than later. You want to crack on if you're going to have a family. I mean, I know a lot of us now, delay starting a family, but all the evidence shows that normal women's fertility starts to decline at the age of 35. So if that's what a normal woman's fertility starts to decline at, possibly it'll start to decline earlier. So definitely start thinking about it earlier. Yeah.
Thank you very much. Moving on to the menopause now. Someone has said, I'm really struggling with the emotions brought on by my cyclophosphamide-induced menopause, and you've hinted that HRT might not be the best approach. Could you please expand on that concept, Dr. Price?
So this is difficult. So if you've got a cyclophosphamide-induced menopause, that suggests you've had it very young. So I think I would be more relaxed about HRT in somebody that age than I would in someone going through a normal menopause at the age of 50. And the reason I'm a little bit hesitant about recommending HRT is that HRT is estrogen-based. Estrogen drives a lot of these autoimmune diseases and can make them worse. Now, however, having said that, if you're in your early 30s, say, and you've had cyclophosphamide and you're going through the menopause then actually all you're doing with HRT then is putting you back to a normal level, not giving you over and above normal. So I think that's a decision that needs to be made on an individual basis. And everything we do in life, and every time we prescribe a drug to a patient, we have to think of the positives and the negatives. So if you're having terrible hot flushes because you've gone through a very early menopause, then HRT may be the drug for you. If you're 55 and you're struggling a little bit with a bit of fatigue and you're asking me, should I take HRT? I'd probably say, actually, no, just keep going. You're halfway there. You may as well stick with it. So I think you've got to be pragmatic and you've got to wait and see. Yeah.
Thank you. Question from Anna, and Anna asks, could you please repeat the information that you gave about paraneoplastic cases? You mentioned that cancer can present after a connective tissue diagnosis. Is it possible to expand on that point, please?
Yes. So that's paraneoplastic disease is really interesting. And actually we do see it. We see it more often than we think we see it. And I think we're always alert if we see a slightly atypical patient. So somebody who presents at a slightly wrong age with a slightly odd history and has some features of connective tissue disease like Raynaud's, etc. And it is described as a paraneoplastic phenomenon. And probably what's happening there is that the underlying cancer is driving the autoimmune process. Now, they say that to call it paraneoplastic, there should be no more than a 2-year gap between the malignancy and the connective tissue presentation. It's most commonly described actually in a condition called dermatomyositis or myositis. And we're always taught, I was always taught as a trainee, that if you see a myositis presenting for the first time after the age of 50 years, you should look for the cancer because they probably have an underlying cancer. Now, that is not necessarily true, but we know that the incidence of cancer goes up as we get older anyway. So I think and in the paraneoplastic patients, if you treat the cancer effectively, often you treat the connective tissue disease. The connective tissue disease symptoms will melt away when you treat the cancer.
Thank you, Dr. Price. Moving on now to a question about intimate health. Someone has asked, I seem to be getting vaginal infections. Do you have any advice?
Okay, and that's very common, and it's to do with the pH of your vagina. So you need to normalize, make it acid. So what you need to be doing, and I think you probably do need a combined approach. It depends on your age, but I'd say most of my ladies with recurrent vaginal infections, I've got them on a regular Vagifem style pessary, which is an estrogen containing little pessary, and I say to them, you have that every night for a fortnight, pop it up every night for a fortnight, plump up the skin, improve the quality of the skin, and then you give them on top a pH balanced vaginal moisturizer like the SVM. And there is also one, which the name of it will pop into my head, that is specifically good for bacterial vaginosis. If you bear with me, I'll think about it in a minute because I know the name, but it's just gone from my head, which is specifically good for vaginal infections. I mean, the other thing to be aware of is, have you got thrush? And if you've got thrush, and it's deep-seated, you may need more than just the Canesten treatment. You might need something called fluconazole, which is a tablet that you take. And the standard treatment of that would be one tablet, but if you've got very resistant thrush, you might need a 10-day course. Yeah.
Thank you. Thank you very much. This is a question from a lady. She says, I'm 39 and I have been diagnosed with PBC and AIH. How common is it to have this together with scleroderma, please?
Okay, so PBC is primary biliary cholangitis and AIH is autoimmune hepatitis. So those are both inflammatory conditions of the liver. And they're autoimmune as well. They are slightly commoner in women as well. And interestingly, we have got overlap. So I've got a number of patients who have PBC, and in fact, I saw a lady this morning who's got PBC and scleroderma and Sjögren's actually. And the problem is that all of these autoimmune diseases cluster. So that if you look at the underlying background, there must be something about us as individuals, you as individuals, that makes you more vulnerable to autoimmunity. And then something triggers the autoimmunity. Well, what is it that triggers the autoimmunity? And I have to say that we don't know for sure what it is, but it's probably what we call a multifactorial hypothesis. So you've got your background genetic makeup with, on top of that, a hormonal vulnerability, and on top of that, something that triggers your immune system. And so it is very common once you've got one autoimmune disease to get another. So I think the actual figure for PBC in association with another connective tissue disease is about 7%. So about 7% of people will have PBC and another connective tissue disease, 7 in 100.
Thank you very much. Thank you. Moving on now to a question about HRT. The question is, would a balanced HRT with progesterone be better?
Yes, it's better than an unopposed, and nowadays they're very keen on that. So they give people like a Mirena Coil, which gives you a low dose of progesterone background, and they give you estrogen on top. So that's better than unopposed estrogen, but it's still estrogen. So you still have to work out, is this helpful or not? So I have certainly seen patients presenting at the menopause having been put on HRT who've got new Raynaud's. New troublesome Raynaud's, which only goes away when we stop with HRT. So I think, the trouble is that no two people are the same. You have to try it and see, but I wouldn't assume that I wouldn't assume that HRT is the panacea that it's necessarily made out to be.
Thank you. Okay, this is a question about relationships. I know that loss of libido and discomfort is often part of the menopause and the perimenopause, but could scleroderma be aggravating this aspect, and is there anything that can help?
Yes. Yeah, in fact, there has been a study looking at exactly this and finding that women with scleroderma did struggle with intimate relationships because they're drier, they're tighter, it's uncomfortable, they've got lots of other things going on. Can you do anything about it? Well, I think being honest with your doctor about it. I have to say, patients often don't volunteer this information to doctors. I now ask all women about vaginal dryness. It's become just part of my routine. And actually, they say, "Oh, yes, I have, but I've never mentioned it to anyone because it's also embarrassing and everything." But actually, we have to be upfront about it. I actually offer people when I see them, I say, "Right, have you got vaginal dryness? Do we need to put you on a vaginal moisturizer? Do we need to do this?" And I think you've just got to be pragmatic about it because it's very important, obviously, a very important part of us as individuals that we have, good relationships and so forth. Is there anything you can do about the scleroderma itself? I mean, you can treat, as I say, the dryness. There's some very good moisturizers and products on the market now that you can use. Is there any evidence that treating the underlying scleroderma may help? Well, possibly. I mean, I know that scleroderma doctors measure your skin score, your Rodnan score. So if they can give you something that can reduce that, that may help. But as you all know, and I know, treatments for scleroderma are very disappointing and very few and far between.
Thank you, Dr. Price, for your answer. We've had another question come in. Does the contraceptive pill have a similar effect to HRT? So HRT and the contraceptive pill. Does the contraceptive pill have a similar effect?
So it can do, yeah. So if I see a young teenager with new onset Raynaud's, so a 14, 15-year-old new onset Raynaud's, I usually say to them, think about having the progesterone only pill. So contraceptions are not all the same. The traditional contraceptive pill was what we call the combined pill, which includes estrogen and progesterone. Interestingly, there's been a move away from that, and most GPs now, particularly with young girls, will start them on a progesterone only product. I think they call them LARCs, long-acting reversible contraception. So I think there is a move away from estrogen products. So I would recommend to them, actually, don't risk getting it worse. Use a progesterone containing product rather than estrogen. And a really good one for sort of like a slightly older lady, maybe, who's maybe had a couple of children and thinks, well, maybe I don't want any more, but I'm not 100% certain, is the Mirena Coil, which is like a mini coil, which it's very easy to put in. It lasts 5 years or so. It secretes a tiny little bit of progesterone locally. It's very side effect free, and in fact, it has a tendency to reduce your periods, and it's really helpful and it's very safe. So I often recommend that.
Thank you, Dr. Price. We've got 10 minutes left for our Q&A session. We have had a couple of questions come in, which may be a little bit outside of the realm of women's health. They're more general about scleroderma. Is it okay?
Yes.
If I put one of those?
Yeah, we'll have a go. If I can't answer them, I'll be honest. So do you?
Thank you, Dr. Price. We'll start with something general. We have been asked, what are the most accurate tests that are used to diagnose scleroderma? So this is about diagnosis, the most accurate tests.
Okay, so scleroderma can be difficult to diagnose in the early stages. Often people start with just symptoms and Raynaud's. There are a couple of very helpful blood tests. So you can have your autoimmune profile checked. The classical antibodies that we see are something called anti-centromere antibody, which we classically associated with limited scleroderma. And limited used to be called CREST. And that's where you get the calcinosis, the Raynaud's, the esophageal dysmotility, sclerodactyly, thickening of the skin, and telangiectasia, little red spots. The other test you can have is an SCL70, and that's classically associated with diffuse scleroderma. Not everybody, though, is positive for those antibodies. And interestingly, some people have unusual antibodies that don't fit quite into those categories. Scleroderma is, at the end of the day, a clinical diagnosis. So it's made by looking at your patient. A really helpful test is something called nail fold capillaroscopy. And that's where they take a very detailed photograph of your nail folds, your cuticles, and they can look at the blood vessels. And there's good evidence that in normal people, you have nice symmetrical capillaries. In people with early scleroderma, you start to see tortuosity of these capillaries, and later on you see capillary dropout. And not only is that helpful diagnostically, it can be helpful prognostically as well. But sometimes patients with scleroderma turn up in clinic and you say, I think you might have it, I'm not sure. Let's bring you back in 6 months or so and see if things have developed. And features that make you think about scleroderma would be late onset Raynaud's. So Raynaud's, as I said, very, very common, 20% plus of the population, classically starts in your teenage years. But if you've got someone who suddenly develops Raynaud's out of the blue in their 30s or 40s, you start thinking, oh, well, that's a bit odd. Why have they suddenly got it? Has something happened? Are they about to develop a connective tissue disease? And the evidence suggests that if you're in that situation and you are going to develop a connective tissue disease, you will progress within a couple of years. So quite often we'll bring people back in a year or so just to see what's happened to them.
Thank you, Dr. Price. This is a question about medications, if that's all right.
Yeah.
My GP says nifedipine is no longer available. I used to take the LA version.
It's been... Yeah.
Now I'm prescribed Coractin SR, but it doesn't suit me quite as well. Do you agree with my GP?
So there have been real problems. It's actually I don't know if it's Brexit or if it's the pandemic, but we've had real problems getting hold of certain formulations of nifedipine. It is still available in some formulations, but you are right that it's not available in all the formulations that it used to be. Now, Coractin SR is a form of nifedipine. There's no doubt about that. It is nifedipine, but it's in a particular form. The nifedipine we really can't get is the faster acting nifedipine, and I'm afraid it's just no longer being made. So it may be worth talking to your GP about, can they get any other forms of it? It is difficult to get. I absolutely agree with them. I think there's one called, I'm just looking it up now, Nifedipress or something like that some people have been able to get, which is a bit nearer the old one. So Nifedipress MR. So you might want to look at that one. So Nifedipress MR. And that's closer to the old formulary nifedipine. But it is nifedipine, it's just in different formulations. But it has been difficult.
Okay, thank you, Dr. Price. We do have a question about symptom management whilst travelling.
Yeah.
If that's okay. I can read it
Yeah.
out. I plan to travel outside the UK during the Christmas break by plane. I've read that people with scleroderma struggle with their breathing whilst flying. Do you have any advice on how I can prepare for this journey? For instance, any medication I could take? I suppose that could be prescribed or alternative.
Yes. Okay. So that you can, if you're worried. So many patients with scleroderma will have lung function tests checked every year or so. If you're worried about flying, and the problem with flying is that the oxygenation in the cabins is definitely lower than we normally experience, and the pressures change. So people who normally manage fine can get into an aeroplane and desaturate, get trouble with breathing because their oxygenation levels fall. If you are worried about that, you can do something called a fit to fly test. Fit as in fit to fly test. Now you'll probably have to pay for that. Our hospital does do them, but they do charge people. And it's basically where you come up and they measure your oxygenation levels and they work out, can you withstand the drop in oxygenation that you'll get at altitude? And the benefit of doing that in advance is that if they work out that you are going to struggle, then you can traveling order oxygen. So it is perfectly possible to order oxygen on the flight if you can show that your fit to fly test has shown you need it for the flight. And if you're worried, it might be best to do that rather than risking getting up in the air when you're suddenly short of breath. Can you take anything to help? Probably not. The only thing we do sometimes advise if you're traveling, obviously putting yourself on a long journey or in an aeroplane could increase your risk of clotting. If you're vulnerable to clotting for any reason, so if you've got an underlying chronic disease or you've got a history of sticky blood or a family member and so forth, there are 3 things that you can do to help prevent clots. One is, it is really important to wear those flight socks. You can buy them in Boots or Superdrug. They're not terribly expensive. They are a bit uncomfortable, but there is very good evidence that wearing flight socks significantly reduces the risk of clots in the air. The second thing you can do is make sure you remain as hydrated as possible. So they never give you enough to drink, soft drinks, I mean, on the airplane. So take with you, you have to buy it after check-in, obviously. Take with you a bottle of water and make sure you drink that during the flight. It'll be a bit annoying because you'll probably have to get up and have a wee, but actually the other thing you can do to help yourself is exercise during the flight. Now, the reason we see problems in flights is because people are sat down for too long in a cramped position. So the other thing that can help is ask for an aisle seat so you can put your legs out and get a little bit more stretched.
Thank you, Dr. Price. There are some questions that we're not going to have time to answer. I'm so sorry. We are rapidly running out of time now. There is one more, and we're going to come back to the women's health aspect now, if that's okay. What natural therapies, or are there any natural therapies that you might suggest for someone who is 50 with some menopausal symptoms such as brain fog, hot flushes, mood swings, aside from HRT?
Yeah. Okay, so just to answer a question I didn't answer properly first time round, we were talking about vaginal irritations, infections and discharge, and the product that went out of my head is something called Balance Active, and it's balance as in balancing on a ball, active, ACTIV, and that can help rebalance the vaginal pH and the vaginal moisture levels, and that's really helpful if you've got recurrent infections and a smelly discharge. That's number one. The second question I was asked about is things that you can do to help you at the menopause. So actually, I wouldn't get too hung up on supplements. The only things I would say is that 30% of the UK population are vitamin D deficient. If you're vitamin D deficient, you will feel tired and run down and achy and weak. So take vitamin D. We should all be taking vitamin D in the winter. The UK sun is inadequate to produce vitamin D. So vitamin D does help. The second thing you can do is stay fit and active. So keep walking. We all need to do 30 minutes of exercise a day, sufficient to get our heart rate up for health. Now, it doesn't have to be running a marathon or going for a jog, just a brisk walk where your heart rate's up but you're still able to speak in full sentences, and that will prevent the muscle wasting that we see post-menopause in women. Vaginal dryness, treat that. Think about topical HRTs, and if you don't fancy the HRTs at all or the estrogen creams, just use the non-hormonal moisturizers. They are the one that I recommended, the SVM, is actually vegan and ticks all the boxes in terms of being environmentally friendly. What else can you do? Take up a hobby, do something new, do Pilates, take your mind off it, keep your brain working. So brain fog is a problem, and the evidence is with all the connective tissue diseases is they cause fatigue, and they cause physical and mental fatigue, and the mental fatigue usually presents as brain fog. So if your brain is tired, it starts to shut down, it stops remembering things. Interestingly, the studies have shown two things that make a difference. Disappointingly, neither of them are drugs, and both of them are things you need to do yourself. So one is exercise, but the second thing is mindfulness, and I would strongly recommend it. There is good evidence supporting it in all of the connective tissue diseases now, and it does help you with that sort of postmenopausal foggy brain.
Thank you, Dr. Price. I'm so sorry we've run out of time. I'm so sorry that we haven't answered all of the questions that came in today. I'd like to say a big thank you to Dr. Price on behalf of all of us at SR UK for giving up your time to be here with us today for your presentation and for answering all the questions. Thank you very much. We do really appreciate it. I'd also like to thank everyone who's joined us today. Thank you for your support. I hope that you found the webinar helpful. If you did find it useful, and if you would like to support us in future webinars, you can do so today by donating £5 by texting SRUK webinar to 70450. That is 70450, and that is basically a £5 donation plus your standard network rate. Thank you again. Thank you, Dr. Price, and we'll see you very, very, very soon. Thank you. Thank you, everybody.
Bye.
Bye. Bye-bye.